So today we'll be looking into two MCQs that were given in the previous past papers regarding biochemistry. So again, completely focused on enzymes. Uh, these are some of the true and false questions that were asked in the initial set of examinations, and since I found this little bit intriguing, I'm going to discuss this. So this is what they have asked is about the activity of enzymes. Again, going a little bit deep into enzyme kinetics. We'll see how this goes, and there are a few chemical scenarios as well that is been stated, and your knowledge about chemical aspects has been tested as well. So the first statement, in a competitive inhibition Vmax is decreased. Yes, the problem is about Vmax. Now if you can remember, Vmax is the maximum velocity in which an enzyme of a given concentration can achieve in a given temperature, and the other set of biochemical factors has to be kept constant as well. So Vmax is the highest rate of activity. Now if you can remember, if I draw the plot one more time, it's something like this, and for an enzyme there will be a hyperbolic curve, and the maximum velocity of the reaction that can be achieved with with the infinite concentration of a substrate is known as the Vmax. Yes. So Vmax is dependent on few factors. It is dependent on the temperature. It is dependent on certain the other environmental factors criteria, and also dependent on the enzyme concentration as well. So primarily we are stating that there is a concentration, that there's a given concentration of enzymes, and to that Vmax is stated. Right. So the question here asks about Vmax, that whether what effect this inhibition has on Vmax. So yes, it's a normal. It's something like this. So in the presence of an inhibitor, there are two types of inhibitors that we come across. One would be competitive, the other would be non-competitive. The non-competitive inhibitor is usually bound to a site that is away from site that is away from the active site, which is known as allosteric. But the competitive inhibitor has a structure which is quite similar to that of the substrate, and therefore competes with the substrate for the active site. But competitive inhibitors are almost all the time it's reversible in action. Most of the non-competitive inhibitors are irreversible in action. So once a competitive inhibitor gets into play, what would happen is that the active site will find two competitors, both the substrate as well as the inhibitor. So its affinity towards the substrate will be reduced. But if the substrate concentration can be increased to an infinite level, then the action of the inhibitor become negligible, more or less negligible. Therefore, at an infinite substrate concentration, that there's a possibility that it can reach back to its normal Vmax level. So, the competitive inhibitor will not change the Vmax. Vmax stays unchanged. But in a non-competitive inhibitor, what will happen? It will reduce the number of active enzymes. Once it is bound irreversibly. It will change the three-dimensional shape of the enzyme, and then cause, which is known as conformational changes, and then will prevent the enzyme from working, and thereby will cause a reduction in the Vmax. So the applicable or the eligible enzymes that are available for the reaction will be reduced, and henceforth what would happen? There will be a reduction in the Vmax. The new Vmax will be less with the non-competitive inhibitor. Right. This could be illustrated well by using a Line-Weaver-Burk plot, but I'm not going to do that because it costs a little bit of time. Right. So the first one, in a competitive inhibition, Vmax is decreased, which is false. It is unchanged. A non-competitive inhibition, Km is increased. Again, what does Km means? Km is affinity. Affinity, it's the Km value is somewhat inversely proportional to affinity. Once the affinity to a particular substrate is high, what you get is the Km value is somewhat diminished. So a non-competitive inhibition. In non-competitive inhibition, usually there will be not there will be the structure of the inhibitor will be quite different to that of the substrate, and therefore it will not be attacking or will not have an enforcement on the active site. Therefore the affinity of the active site is more or less unchanged. So in non-competitive inhibition, Km is increased. That's something which is false, and the Km value is only changed in competitive inhibition. So again, this is a false statement, right? False statement. Asparaginase is used in treatment of leukemia. Again, a clinical scenario. Um, Here, what we are looking for is the activity of asparaginase. What does asparaginase do? Asparaginase is an enzyme which will act on asparagine and break it down to aspartic acid with ammonia. Without the presence of asparagine, which is an important constituent in the formation of DNA, the production of DNA, RNA, and even certain proteins are reduced. The production is reduced. So what will happen? Now, the problem at the initial state of cancer is the fact that it has uncontrolled division, and therefore there is excessive production of cells. So for the cells to produce, there should be ample amount of DNA. That once the DNA production is reduced, in turn, what it causes as a consequence is that the cellular division will be halted as well. So asparaginase can be used as a chemotherapy. Now, which is quite common. Now, these are some of the facts that you might not um, see in your basic clinical studies, but once you go to your medical appointments, when you start doing internal medicine, of course you will see number of patients who have been started with this chemotherapeutics, and it is something very commonly seen in patients with leukemia, especially lymphoid leukemia. It is a drug that is used. So this is a true statement. Neostigmine is a competitive inhibitor of acetylcholine esterase. Yeah. The thing is, neostigmine, if you have not come across this is a therapeutic agent, neostigmine, and even there are a few other long-acting ones such as pyridostigmine. These drugs are used in the therapeutic in therapeutics of a disease entity which is known as um, myasthenia gravis. Now, if you can remember myasthenia gravis, what is the mechanism of what is the pathophysiology of myasthenia gravis? There are antibodies. There are antibodies which will destroy nicotinic receptors. Destroy nicotinic receptors. Usually, the nicotinic. Where do you find these nicotinic receptors? Usually, I find them in the places where there is muscle spindle fibers, where acetylcholine gets bound to these nicotinic receptors to for the action of the muscles. So what would happen once the nicotinic receptors are broken down? The acetylcholine does not find a receptor to bind into, and therefore the muscles will show weakness. It is because there is no total obliteration of the receptors. However, the receptors are partly reduced, and henceforth the number of spindle fibers that will be activated once a certain stimuli crosses will be lessened, and therefore the force that is to be produced by a certain muscle would be halved or reduced. So what you would experience is weakness. Now this is quite common for you to see problems in most muscles. So one manifestation where people would come and present themselves is with ptosis. What does ptosis means? Ptosis is drooping of eyelids. Drooping of eyelids. How does this happen? It's because now there's a muscle which is known as levator palpebris superioris. Need not know, but it's a muscle which is important in making sure the eye is kept open. But because of the weakness, what would happen is that this muscle will not work, and therefore there is drooping of the eyelid. The drooping of the eyelid. Specifically, this happens closer to the evening rather than in the morning. So evening ptosis. Because of this, the people might come and say, you might see a little bit of a discrimination between the eyes, and the people might come and say that there is a diplopia. They will see double vision or some sort of obscurations in visions. These are the normal complaints that you would see in your clinical practice. So diplopia, drooping of eyelids, muscle weakness, this relates or directs you to a certain disease entity which is known as myasthenia gravis. It is because of the antibodies that destroy the nicotinic receptors. So what do we do in return? What we do is, now the nicotinic receptors are broken down if the antibodies get bound to the receptors. If the antibodies get bound to the receptors, but we can prevent this from happening where the where there will be, since these antibodies uh, are competing with the acetylcholine. If we can increase the amount of acetylcholine that is present at the sites of the receptor, we can make sure that the antibodies will not come into play. How is this done? This is done. The acetylcholine is usually broken down by an enzyme which is known as acetylcholine esterase. So what we do here is that we block acetylcholine esterase. This is not something that is this is not similar to that of organophosphate poisoning, because in OP poisoning again acetylcholinesterase is blocked, but it is blocked irreversibly in a very permanent sort of a manner. But here what it does is that the neostigmine or the pyridostigmine, which is a long acting one, what it does is that it competes it competes and binds to acetylcholine esterase reversibly, and it competes with acetylcholine so that it binds reversibly and prevent acetylcholinesterase from working, and therefore it will, once it stops work or once it is reduced from working, or the action is reduced, what would happen? Acetylcholine will start to accumulate. Acetylcholine will lead to the possibility of uh, will prevent the antibodies from binding to the receptors and destroying them, and therefore will reduce the disability that is seen because of the disease. So pyridostigmine is the better drug. Neostigmine is a more or less an acute. It does not have that much of a half-life. It works once you give a neostigmine dose. You can see in good improvement of symptoms as soon as possible. If a patient comes with ptosis and you give a dose of neostigmine, you will see that the drooping would more or less be succumbed and will improve in a very short period of time. Neostigmine is a drug that is usually utilized when people are given epidurals. What does epidural means? Epidural anesthesia. Usually once people are given anesthetics and there's muscle there where because of the anesthesia, the muscles are not allowed to work. The muscles are paralyzed just until the surgery takes place. But once we need to revive the patient, we can give a neostigmine dose because it will act quickly and will reverse the action of the anesthetics and make sure that the patient comes back to his normal state in a very quick succession. This is quite important because sometimes the anesthesia can lead to sometimes the diaphragmatic paralysis, which can cause respiratory compromisation. So before getting into that sort, once the patient is revived, give a little bit of neostigmine to revive the patient and bring the muscular contraction back to its original state. So it's again the same drug with different half-lives. Pyridostigmine is the better drug to use in myasthenia gravis because it has a very long half-life. It will act for a longer period of time, and you can take it as a daily or a daily dose, or sometimes even a BD dose twice a day. But neostigmine is something very acutely working. It works within matter of seconds and then goes off. So neostigmine, so it is said that neostigmine is a competitive inhibitor of acetylcholinesterase. Yes, reversing anesthetics and even has good improvement in people with myasthenia gravis. So a true statement. Glucose 6-phosphate dehydrogenase acid in serum. Where do you get G6PD? Now this is a very common sort of a question. Again, biochemistry, this can come in various forms. The versatility of G6PD is quite high. If I can, I'll do a question regarding G6PD, where I would like to entertain most of the statements that are given in an MCQ. But just giving a little bit of recap, G6PD is an enzyme which works in pentose phosphate pathway. What does it do? It is involved in the production of something called NADPH, a reducer. What is the importance of NADPH? It makes sure that the glutathione that you see in the RBC membranes is maintained in its reduced state. Why is that important? Because red cells are subjected to various radicals. It could be radical oxygen species because it's working closely with oxygen, and there are transitional elements such as iron which can cause the production of ROS. Now the ROS will damage the red cell membrane, but it is prevented by the presence of glutathione which is present on the red cell membrane that will act on the ROS and prevent it from damaging the membrane. So glutathione has to be maintained. The glutathione is kept by NADPH. If there's a fault, if there is a defective quantity of G6PD or a defect within the G6PD enzyme itself, that will lead to disruption of the pentose phosphate pathway and malproduction of NADPH, it has a possibility to not serve well in maintaining of glutathione. So what would happen? Primarily, there is a possibility that these red blood cells can be destroyed by the ROS species and thereby cause a disease which is known as hemolytic anemia. So people who are coming with anemia, and there is also manifestation of jaundice, which is yellowish discoloration of the body, because now once the red blood cells are broken down, they are converted to form bilirubin. However, there is excessive production of bilirubin. The liver does not have the capacity to conjugate, therefore it will form indirect bilirubin. The indirect bilirubin will be manifested as jaundice. So jaundice, people come with yellowish discoloration, there is anemia, and when you do a blood picture, you see white cells, broken cells, then you know that this is a possible, that this patient might be having G6PD. So what is the investigation that you can do as an initially? What you can do is you can take blood, you can do a serum test, you can assay or quantify the amount of G6PD that you see in serum. So it is what is it is the statement that is given here. So this is a correct or a true statement. Yeah. The next question. Right. This is a question that has been repeated in multiple terms when it comes to biochemistry. So the use of a biochemical biomarker is something very important in our clinical practice. So see again, or clinical questions are the ones that are being questioned. So biomarkers. Where do you use biomarkers? Biomarkers. Uh, what I can say is it's simply an indicator of a disease. Biomarker is an indicator of a disease. Now, for an example, let's assume that's a cell, and the cell will undergo some sort of a disruption. It So what would happen is there are chemical constituents that are found within the cell which will move out into the serum. Now, if we can quantify or qualitatively analyze these chemical constituents, we know that this cell is the one that has been jeopardized. So, but the problem comes is this. Now, if the same chemical is found in other cells as well, it is not very specific. Therefore, by quantifying it, we do not know whether the specific cell is the one that has been disrupted. So, this biochemical marker or the biomarker has to be specific to a cell. Now, if I assume that there is a myocardial damage, the heart cells will start producing, will allowing certain chemical constituents pass into the serum, and if I can assay that, or if I can analyze it, I know that there is a problem with the heart. But the problem is but whether this is possible, with whether simple damage in the skeletal muscles can cause the same elevation of the biomarker, then of course it becomes not very valuable, right? So it should be specific, and also it should be very sensitive as well. So the slightest damage, if it can produce larger quantities that can be chemically analyzed, yes, then it's good. So specific and specificity should be there in a good biomarker, right? So in a MI, there are multiple number of biomarkers that we utilize. Usually, the biomarker that is used in clinical aspects is troponin I. Troponin I, even troponin T is good, but troponin I and troponin T are the major ones that are being used, but which are very specific and even sensitive for the heart cells. But troponin C is never utilized because it is common to both skeletal as well as myocardial cells. But when it comes to troponin I and troponin T are large insoluble biomarkers which are where there is better specificity. There are isomolecules which are well seen in heart rather than in other muscles, right? I'm not going to go into specifics about these few. Troponin I and T has multiple isoforms. The isoform that we analyze is somewhat specific to heart cells. So you would see troponin I being elevated after around 3 hours. It will take a little bit of time for the enzyme to be released, and once it is released, it will start to increase in the serum levels and go to a certain peak value. Usually, this takes a little bit of time. If you can remember, it's good, but it will take around 1 day, 24 hours, more even less than, it's more than 24 hours. So it will come to a peak value and from the peak value it will start declining because it is being cleared off either by the liver or the kidney. Once it is cleared, it usually takes around 14 days. After 14 days it comes back to its normal level. Right. So it's troponin I and T, which are the most common ones, but the question asked here is about it's about actually the timeline. So here I have taken this is an illustration where where different types of biomarkers are entertained. The first biomarker to be elevated even within 2 hours of a chest pain. If there's myocardial infarction, within 2 hours, myoglobin would be elevated. But the problem with myoglobin is that it it is common for both skeletal muscles as well as cardiac muscles. So we do not know whether it's a damage in the skeletal muscles and or the heart muscles. So it is not specific. So the utility or the importance of myoglobin becomes quite negligible when it comes to differential diagnosis. So the next one, within again 2 to 3 hours, you would see. In fact, yeah, in 2 to 3 hours. In 2 to 3 hours, you would see another biomarker coming into play, denoted by orange color. It is known as creatine kinase. Now, creatine kinase is a enzyme that you would see many, but uh, the good thing about creatine kinase is that this creatine kinase usually peaks in less than 12 hours and goes back to its normal level in almost 2 to 3 days. The good thing about creatine kinase is that let's assume after the chest pain, there is a possibility that the patient might be having a chest pain back again in the following days. It could be in the third day, it could be the fourth day or fifth day. But if you do your troponin levels, the troponin levels are more or less constant. You wouldn't see that much of an elevation. So by looking at the positivities of troponin IOT, you cannot come into a conclusion that a reinfarction has happened. But creatine, you know that creatine kinase is 0 after 2 days. So after let's assume the patient is having a chest pain back again in the fourth, then you can do a creatine kinase level, and with the symptoms, with the manifestations, you will know that there has been another reinfarction, right? And something that you need to know is the creatine kinase has 3 isoenzymes. Isoenzymes means the same structure, the same function but different structures. There's something called CKMM, which is seen most in skeletal muscles. Then there's CKMB and CKBB, which is seen in brain. MB is the one which is present mostly in cardiac cells. You can quantify the isoenzymes. For an example, you can get the percentage of CKMB from the total CK, from the total CK, from the percentage of MB from the total creatine kinase you see in a serum level. If this is greater than 5%, you are very much sure that this has come from heart, because no other cell will show creatine kinase MB of a greater percentage. Usually, if you now these are some specific stuff that you need not remember much, but again, usually in a normal muscle cell or a skeletal muscle, you would see less than 2% of creatine kinase MB. 98% of creatine kinase is of MM type, but in heart, usually only about 70% is in MM, whereas MB isoform is present around 20%. So if you see something more than 5% in your differential assays, then of course you are quite affirmative about the fact that this is an infarction that happens in the heart cells, not anywhere else. Got it? Yeah, these are few These are a bit tough than that is required, but again this is a question that has appeared in your in the Colombo paper. So um, better to know all these stuff, even though these are bit beyond your level. Yeah, again, the timing has been given. Now there are many other um, good or novel biomarkers, not much utilized in Sri Lanka, but yeah, there are a few other things that you need to remember. There's something called fatty acid binding protein is elevated the fastest. It has a very good sensitivity as well. It is the fastest. So you have now, once a heart attack takes or infarction takes place, you have to stay around 3 hours to get a troponin I positive for the diagnosis. That will cost a little bit of time. That's problematic. If you have to wait 3 hours until the infarction will proceed for a longer duration, and you will not have good morbidity from the patient, because the patient will be succumb to more complications. So if it is better if you can get reading as soon as possible, instantaneously as possible. So fatty acid binding protein is something that is used in the world, which will show quick detection. It is the first to be detected. It's around 1.5 to 2 hours, but most of the time, if it is given as a MCQ statement, the first biomarker to be detected is myoglobin, because fatty acid binding protein is not something that we use in our country. Creatine kinase MB takes 2 to 3 hours. Then there's followed by troponin I. Troponin I 3 to 4 hours, but keeps on for around 2 weeks. This can extend to more than 14 days. Got it? Then there are other biomarkers as well which can be elevated, such as aspartate and aspartate transaminase, which is AST. ALT is more specific of liver. It can elevate as well because of some of the uh, there will be blood retaining within the heart, which can cause um, um, which can cause blood to be stagnating in the liver cells, that can cause liver dysfunctionalities, causing a high ALT value, but not very specific. ALT can increase in a heart attack, but AST is the better biomarker. AST will be elevated. Again, keeps on for around 3 to 5 days. And then there's LDH. Earlier, LDH was a very prominent one because it was quite widely available in most of the hospitals. But now it is because of the lack of sensitivity and specificity, we are not using that. However, there are many isoforms of isoenzymes of LDH. There's LDH 1, 2, 3, and 4. One found in RBC and heart, 2 found in WBC, 3 found in lungs, and 4 found in pancreas as well as kidneys. So if you can do LDH1, which is better and higher specific and less cost effective, very cost effective as well. If you can do LDH1 and isolate it, you will know that there is a that this patient with the clinical symptoms, that there is a possibility that patient might have undergone a myocardial infarction. What you usually get is LDH1 to 2 ratio, because in hemolytic anemia and other sorts of blood dyscrasias, what you get is LDH1 and 2 both getting elevated, usually 2 greater than 1. But in heart problems, LDH1 is the one is the isoform that you get elevated in comparison to LDH2. Usually this would be greater than 1 in a heart problem. Right, there are a few other biomarkers that I just need to mention, not very important, but better know. There is something called um, pro-BNP. I'm not going into specifics because this is something very this will be taught to you in your endocrine physiology. There's something called BNP, brain natriuretic peptide, which is elevated in heart failure. So for heart failure, we do an assay which is called pro BNP to identify heart failure. Better than pro BNP there is which has higher sensitivity, which is called nucleotide pro-BNP. This is because after the production of BNP, there's a nucleotide the nucleotide bases which will be broken down because of now you know that most of the proteins that are produced in the body undergo post-translational modifications. So these nucleotide bases will be cut off and sent out through the blood to the kidneys where it will be excreted. So by quantifying the NT pro BNP NT, this is how uh, BNP is initially secreted. So by quantifying this, you can come into a conclusion of heart failure. So this is very sensitive, but of course the half-life is much longer. Therefore, for acute heart failure, we can do pro BNP rather than BNP nucleotide NT version. Right. So these are few facts that I just wanted to say. And going back, now let's look at the question. Substances which increases 12 hours after MI. So they have given a specific time frame. So this edges at the fact that you need to remember some of the time durations as well. Where the peak is detected and where the first first detection takes place. So this is bit tough than that I expected. 12 hours after MI. So the latest the biomarker which will be released into the blood at the most late stage will be, if I know, yeah, it's given here. After 12 hours, it is LDH. This is something that most of the time, because this was the one that was earlier used, 12 hours. So this is the answer. This might have been a question where a single answer was to be identified. So single best answer, SBA. LDH is the better answer. All of these would be elevated, but in different time periods. In fact, I am not very sure about when ALT and gamma, because these are not very relevant biomarkers in circumstances of MI. Creatine kinase, you would see something within 2 to 3 hours. ALP again, if you can, ALT is given. ALT is given. ALP is the one we are not very sure. This is around 10 hours. But this is a quick answer that requires your direct attention. So something that you need to keep in mind. LDH is the latest one, which will take a little bit of time. So 12 hours is the that mark limit. Right. So I have gone through two questions which has been very prominent and has been asked in several manners, and most of the time these students find it a bit difficult to tackle them as well. So I think that with the discussion I have provided a better understanding of these questions, and you will be able to give a good answer if this is posed you as well in your coming exams. So thank you for joining.